everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we're going to be addressing atherosclerotic heart disease. So atherosclerosis is actually the buildup of fats, cholesterol, and other substances in the artery walls. And the buildup of cholesterol plaques in these walls of the arteries are causing or develop narrowing and obstruction of the blood flow. And then these plaques may rupture, and that is when we have an acute occlusion of the artery by clot, which is our heart attack or a stroke.
Yeah, so atherosclerosis can occur in actually any artery in the body. And we're going to primarily today talk about heart disease, but we have to remember that whatever's going on in your heart is probably going on other places as well, in your legs, in your brain. It's a major cause of erectile dysfunction. So erectile dysfunction sometimes can be a warning sign of heart disease. There's many things that are affected by atherosclerosis. And when we talk about it in the heart, we're talking about the moderate to large size blood vessels in the heart. But keep in mind that this is just one area that can be affected.
And like you said, there's different sizes of arteries and macrovascular, microvascular, like you said, even the eyes are known as microvascular. And that's actually a lot of times a forewarning as well. And you're seeing your eye doctor, even though you can see fine, I highly recommend to follow with your eye doctor to get a look at the vasculature in your eyes.
Exactly. And this is such a big topic that we're eventually going to have another podcast on microvascular disease. So heart disease is the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. It's when we talk about other disease states, say we talk about kidney disease, people on dialysis, say we talk about diabetes. Those people don't die from those diseases. They end up dying from heart disease because heart disease is affected by other disease states. So one person dies every 33 seconds in the United States from cardiovascular disease. About 695,000 people in the United States died from heart disease in 2021, which is 1 in every 5 deaths. Coronary heart disease is the most common type of heart disease, killing 375,476 people in 2021. About 1 in 20 adults aged 20 and older have heart disease, which is about 5% of the population. And when you say that younger people have heart disease, most of those people are asymptomatic, so they definitely don't know that they have heart disease. In 2021, about 2 in 10 deaths from heart disease happened in adults less than the age of 65.
I find that scary.
Right. And so I will say that, to me, one of the scariest subsets of the population is young, healthy people who think they're invincible because they actually lead a fairly decent lifestyle. They may eat healthy, they may exercise, but then they don't take into consideration genetics, and they ignore the fact that they may have had a close family member who died in their 40s of heart disease. In the United States, someone has a heart attack every 40 seconds. And every year, about 805,000 people in the United States have a heart attack. Of these, 605,000 are a first heart attack. 200,000 happen to people who have already had a heart attack, and about 1 in 5 heart attacks are silent. That means that the damage is done, but the patient is not aware that they had a heart attack. And how many times have we done an EKG in the office where the EKG has clear signs that this person has had a heart attack, yet they don't know it. They've never been told. They've never had symptoms. And that silent heart attacks are more common in diabetics and people with chronic illnesses.
Well, and like we've already said, having a heart attack is just proof of having atherosclerosis. So you already have it. And if you had a heart attack, you're at risk for another one. So we have to definitely take in.
Exactly. And many times your first heart attack is fatal. So you don't get a second chance. So what are some of the risk factors for heart disease?
There are several. So high blood pressure, high cholesterol, smoking, diabetes, metabolic syndrome, or just being overweight and obesity. Typically, it's in that midsection there, the increase of the visceral fat specifically. An unhealthy diet. I feel like this is so obvious, and we've talked about it on every podcast we have. So go back and listen to our nutrition podcast, listen to Leaky Gut podcast. But the unhealthy diet, I mean, it's our Americanized ultra processed diet. The lack of physical activity is huge. How many people are sitting at a desk job now or working from home, but they're workaholics maybe and not taking time to go exercise, excessive alcohol use, and even air pollution.
And all the ones that you just listed are modifiable risk factors. And there's others that are not modifiable. And again, it's going back to genetics.
Right.
Family history plays
Yeah.
a huge role, but also your ethnicity. So we know, and we've talked about this in other podcasts before, that people of Asian descent, people from India and Pakistan, they're the people that can potentially have heart attacks in their 30s and 40s.
Absolutely.
And so just because you have a healthy lifestyle, you can't beat your genes, and you still have to be on top of this. So deaths from cardiovascular disease jumped globally from 12.1 million in 1990 to 20.5 million in 2021, according to the World Heart Federation. Coronary vascular disease was the leading cause of death worldwide in 2021, with 4 in 5 cardiovascular deaths occurring in low and middle income countries.
Wow. So what are some causes of heart disease, would you say?
So like everything else we've talked about on our podcast, on every single podcast, inflammation. Inflammation is number one. Every disease state, the underlying cause and the underlying issue that causes problems is inflammation. So the first thing we need to do when we're dealing with heart disease is reduce our overall inflammatory burden. And we talked about toxins. We talked about different foods that affect inflammation. Gluten is very inflammatory. Sugar is definitely inflammatory.
Very.
And which leads us to the next cause, which is insulin resistance.
Right. And sugar and carbohydrates is much more of a problem than the dietary cholesterol that people always think. Tell us a little bit about the history of when they started removing fat from our foods.
Exactly. So in the 70s, we unfairly probably started accusing dietary fat and dietary cholesterol for causing heart disease. And that's when doctors started telling their patients, stop eating eggs, all right, and stop eating red meat and stop eating fat. And we're not saying that you should eat all those things, unlimited and all you want, but at the same time, they're definitely not as bad as we made them out to be. And then we switched that for people starting to eat more carbohydrates.
Right.
And as the carbohydrate intake went up, then what happened? Obesity went up, heart disease went up, diabetes definitely went up. Fatty liver disease. Fatty liver disease is actually going to be the diabetes of the future. I think it's going to be a major disease state that you're going to be hearing a lot about if you haven't already heard a lot about it. We're having young kids now requiring liver transplants from fatty liver disease.
It's terrible.
Yeah. So,
and think about it. I mean, when you're getting a low-fat food, right? Say you're getting sour cream or cream cheese or any of those that have fat, right, naturally from the milk, and you get low fat, they have to fill it with something else. They can't just, let's just remove the fat. No, they're putting other things in it. So you have to read your labels, and people don't realize that. I mean, that makes it processed as well, even more processed.
Exactly. We're already exposed to enough toxins in our life. Why expose ourselves to even more through the foods we eat?
Exactly. Now, what I want everybody to understand is having mild atherosclerosis doesn't mean you have symptoms. You could be walking around chewing gum, talking, enjoying life, eating and drinking, and then not even know it.
You almost never have symptoms, which is why, and when you do have symptoms, they're largely ignored as not being related to atherosclerotic heart disease. Like I said earlier, erectile dysfunction.
Right.
It's a major symptom. And anytime we have a young patient who comes in complaining of erectile dysfunction, we need to do a vascular workup.
Right. And also another one that I like to, people don't realize, pain in your legs. You can have pain in your legs, and we have, ankle brachial index that we can check in our office to check the vasculature for the peripheral arteries, which is the arteries in your arms and legs.
So if people do have symptoms, what are some of the common symptoms that
Right.
would have?
The most common, I'd say, is shortness of breath with slight exertion. So if you're out walking and you're short of breath, or if you're exercising like you normally do, and then all of a sudden you're like, wow, why am I so short of breath? You can also have chest pain or discomfort. That's a classic that people just say they have. But this doesn't mean heart attack discomfort. This means hey, I'm doing something and I feel a little tightness in my chest and I'm not sick. What else could it be, right? Another one is pain in your back, your shoulders, neck, arms, anywhere in this upper area. Feeling dizzy or lightheaded, heart palpitations, fatigue is a big one, nausea or vomiting, or a lot of times the feeling of persistent indigestion. So if you're popping Tums and it's not getting better, this is something you need to talk to your physician or provider about.
In the last couple of years, I would say I've caught at least 3 patients with significant heart disease whose symptoms were all indigestion, heartburn, and they felt like they were having reflux, and it wasn't. It was heart disease.
Right. And then, symptoms of a heart attack or stroke are when the plaque actually ruptures. But our goal in our practice of medicine is to actually prevent and reduce this from happening. We do a lot of specific testing in our practice. And so once again, going back to even if you are quote unquote the young and healthy, you're a runner, you work out, you lift weights, you're eating healthy, and your goal is, to beat genetics like I am, it is now that is impacting your future. And that is what you have to realize. So don't forget about going for your yearly physicals. Just because you're young, go for your physicals. Get your blood work done every year at least, and that's when we can determine what your future assessment is.
And let's talk about who should be screening you for heart disease. Okay, so cardiologists are great. Cardiologists are really good at what they do, and some of my best friends are cardiologists, but a vast majority of cardiologists are not preventive cardiologists. So a cardiologist is someone that typically you would see after you've had an event or after you've already had a problem. Primary care doctors are probably the ones who should be assessing and identifying heart disease in the early stages and doing the preventive stuff, but it never happens. So typically what happens when people get tested for heart disease, the first thing they have is a basic cholesterol test. And I will tell you that in my experience over the years, I find that the basic cholesterol tests are almost worthless. They're not helpful. For many years, in fact, people were just going by the total cholesterol number, which is completely worthless because that takes into consideration your good cholesterol, cholesterol that's not so harmful, and adding up the weight of all these different cholesterols.
Right. And a little anecdote about that is when my parents were getting life insurance on me and I was a college athlete, probably in the best shape of my life, eating wonderful, clean. We were on strict diets, exercising more than, it was like a full-time job. With the blood test they checked was just a total cholesterol. They didn't even do any of the other stuff and it kept coming back high, quote unquote high. And they were saying I had high cholesterol. And luckily my mom was an advocate for myself. She's a nurse and she has background in medicine. So she was like, no, this is impossible. There's no way. And so they said, okay, we'll come redraw it. They drew another total cholesterol. It came back high. She's like, no, you need to draw more. This is not possible. So sure enough, my HDL was like 120. And that was the only factor that was driving up, the total cholesterol.
So let's talk about HDL. HDL for the longest time was called the good cholesterol, which technically it's not. It helps pick up cholesterol and return it back to the liver. And so HDL can be beneficial. But there is also some cases where a very, very high HDL is not a good thing either. It can be dysfunctional HDL. So we need to know, is the HDL effective? And there's different classes of HDL, which people don't almost never look at, HDL2, HDL3. And these things need to be identified. Then we also have triglycerides. Triglycerides store excess calories from carbohydrates in the blood. And then when we talk about blood tests, we've said this before in our podcast, we're talking about reference ranges, which are not optimal ranges. We're talking about optimal ranges. So the reference range for triglycerides is probably not what I would consider optimal. Most doctors are okay if your triglyceride levels are under 150. But realistically, your triglyceride levels should probably be 70. And another great thing to look at is your HDL triglyceride ratio, right? So you want to be in that 70-70 club where it's a 1-to-1 ratio where your triglycerides are 70 and your HDL is 70. That's excellent. And high levels of triglycerides can lead to other diseases as well, like fatty liver disease and pancreatitis.
Right. I mean, if triglycerides are over 500, that alone is putting you at risk for having an acute bout of pancreatitis. And people don't realize that. And another marker that we look at is the LDL, which I always say is the bad cholesterol, right? And we're going to dive into a little more information about that. But typically, this is a calculated LDL. It's by the Friedewald equation. Do you want to elaborate on that? Or
Yeah, so the Friedewald equation was a calculation that they came up with in, I want to say, like 1972. It's been around for a long time, where they didn't actually measure the LDL. They took the triglycerides, divided them they took your total cholesterol. Then from that, they subtracted triglycerides divided by 5 and HDL. And what was left, they said, was your LDL. Now, if your triglycerides are sky high, then you're going to get a falsely elevated number.
Most of the time, it can't even be calculated. It literally says LDL unable to be calculated due to triglycerides being so high. So that's why we like to check the direct measurement.
And now we can check directly measured LDL, which is why I don't understand why people just don't do it. Why still use a calculated LDL?
Right. And in fact, calculated LDL can underestimate the LDL in comparison to the direct measurement.
So all those things we just talked about are things that you would find in your basic cholesterol panel, which is what I would say 99% of people have done by their primary care doctors. But there's so much more. There's so many things that we can do that are so much more beneficial. So let's start with the LDL particle number. All right. In our practice, we do an LDL particle number on everyone, and there's different ways of doing that. There's the NMR test, which is kind of like a MRI of your blood that some labs do. I think LabCorp does that.
Right.
And then
there's the cardio IQ that Quest does.
Right. And we tend to do more cardio IQs in our practice. So ideally, you want to see the LDL particle number under 1100. And we have so many people who come back with normal basic cholesterol panels, and their LDL particle number is sky high. Then when you're looking at the LDL particle number, you also want to look at the pattern of LDL. So there's pattern A and pattern B.
And pattern A is normal and pattern B is bad.
Right. Pattern A is the big fluffy LDL. So when you do the basic LDL, you're actually just taking the weight of the LDL.
Right.
And that doesn't take into consideration the big fluffy ones and the small dense ones, because they can equal the same amount of weight, but they don't carry the same amount of weight as far as importance. Right. Another number that you can look at is the apolipoprotein B, the ApoB, and some people call that the poor man's LDL particle number. And that's a great test to look at if you're not having an LDL particle number done, because every atherogenic particle, which means every particle that can cause damage in the blood vessels, has an ApoB attached to it. So a single ApoB molecule includes the VLDL, which is the very low density lipoprotein, the IDLs, and the LP(a). It's not an expensive test. It's a very cheap test. So I would have your doctor run that test on you. And honestly, that's the test I think in the future we should be using to target what ideal number should be. So we have ranges. So someone who's had a cardiac event, we tell them your LDL should be under 70 in this country and under 50 in Europe. And I believe the European standards are better.
Right.
But I still think the ApoB should be a better test for that. And then another poor man's LDL particle number is the non-HDL cholesterol, which can be calculated through a basic blood test. And we won't get into that. But these are all surrogate markers of LDL particle number. And actually, the ApoB has been shown to be have the strongest correlation to heart disease over all the biomarkers we test. Then we said before, there's different types of HDL. You can do the HDL fractionation. And it's important to know that the quality is more important than the quantity when it comes to HDL.
Right.
Another test that we think that every person should have checked at least once in their life is something called the LP(a) or lipoprotein A. That's a low-density lipoprotein variant that is genetic. And it's something that right now we can't do much about it, but it increases your risk significantly.
Not yet. Yes.
Not yet.
It's on the horizon.
And there are great clinical trials on things that will lower this. But you want to know.
I do know, there's a lot of research coming out with this. It's becoming more aware, I would say. I guess the research has been done and they continue to research, but I like that this is now making a presentation at our preventive cardiology conferences that we've gone to. And this we know is an independent risk factor for heart disease.
And it still astounds me how many patients have never had this checked. We have patients new to our practice who have a strong family history, and they don't know this number. And not only that, but if you have heart disease or if you have high Lp(a) and you have children, no matter how young the children are, you should have them tested too. You want to make sure, because you can at least modify their other risk factors for now until we have a treatment for the high Lp(a) that's more readily available. We have treatments, but they're not readily available right now. Then the treatments that we have right now for the high Lp(a), you can do niacin, aspirin may help. There's certain medicines that are out there, inclisiran, Leqvio, they may help.
Right. But in fact, statins have a chance of increasing this, but it's just minimal, right?
Right.
Okay.
And then there's other tests that we can run.
Well, I kind of want to go back actually and talk about the Lp(a). I like, this is my little description that I create for my patients when I'm discussing this in the room to explain how this is an independent risk factor. And it's basically Lp(a) is an add-on to the LDL particle. So if you don't, it's like a tail. And so if you don't have the Lp(a), you don't get this tail. But if you genetically have this tail attaches to all the LDL particles you have. So it's very important to keep your LDL particle low and your LDLs in general, right? You want your LDL volume to be low, but the particles is what we really look at as a secondary information, for the patients at this time. But the way I describe it is this little tail is very damaging. And as those LDL particles are going through the blood vessel wall, it kind of scratches. I think of it as like scratching the wall, kind of like Hook on Peter Pan when he's going through the house, And this is just so, this is independently creating damage throughout the body. And so you want to have as little particles as possible when you have this condition. And we'll talk about some natural things that can help improve or repair that lining of the artery wall. But that's the way, just to give you a visualization rather than just numbers.
Right, exactly. And while we're talking about damaging to the vessels, let's talk about what the cholesterol does and what happens with the inflammation. Your blood vessels are made up of layers. Okay, and so there's a layer of the blood vessel where all the damage occurs and the inflammation occurs. And that layer is somewhere in the middle of the other layers. And so as that starts filling up with junk and debris, people tend to think of cholesterol as sticking to the insides of the walls of the blood vessels, like calcium in a pipe in your house.
But the blood vessel walls are quite porous. You have to look at it that way. We describe it as like a tennis net, right?
Exactly.
And so we have to look at as the first layer or first few layers are very porous. They're like a tennis net. And so when you have these particles or triglycerides and these fats coming around, they can get inside and go through that net and get to the middle layers.
Exactly. The smaller, denser ones getting a lot easier than the bigger, fluffier ones.
Right. I use the volleyball versus golf ball analogy, right?
That's a good one. And then let's talk about some other blood tests that we can do. There's the hsCRP, high sensitivity C-reactive protein. That's a marker of inflammation, and that's generally picks up inflammation anywhere in the body. And we tend to see that people with heart disease, that number is not so high. It's in like the 2, 3, 4 range, somewhere down there. Whereas if you have a hsCRP of 10, then that means that it's probably not cardiac. It's probably something else going on.
Could be rheumatologic or just generalized inflammation.
Right.
But hence, I always tell people, we know inflammation in general can cause issues like cancer and heart disease. And so you need to get that inflammation down anyway.
Exactly. You need to control your inflammation.
And now I know they're also looking at uric acid.
Exactly.
And I found this really interesting that higher uric acid levels are being found to be an increased risk factor for heart disease.
Yeah, and that's inflammation as well.
Right.
Another test that we can do, a blood test, is the LPPLA2, also known as the plaque test. And we use these tests in conjunction with each other to just give us an overall picture. Like each one gives us a representation like, yes, this one increases your risk a little bit. This one increases your risk a little bit. And you add them all up and your risk is increased quite a bit.
Right.
And so we know that on this person, we may need to be a little more aggressive.
Correct. And correlating it obviously with their lifestyle as well. Right.
So other than blood testing, there's other diagnostic testing as well. Let's start with the one that most people know as the EKG.
Right.
EKG is not a screening test for anything. We don't use it as a screening test. We do an EKG on our patients who are asymptomatic, largely just to have a baseline EKG. Because if something happens down the road, you want to know, is there a change? Did their EKG change?
And what I want people to know is I look at the heart. I'm going to say this analogy, but I'm not sure if it's exactly right. But as a house, and the EKG is the electricity inside that house. So this is the conduction. So it'll tell us the rhythm. And if you're skipping a beat, and yes, it can show signs of heart attack because that's when it is stopped. So that rhythm stops, in theory. But then, you look at the inside, you have the echocardiogram is another next level up, I feel. And that's looking at the plumbing on the inside of the heart. That looks at the valves and the flow of the blood in the heart.
And the muscle itself.
And the muscle itself, exactly. And it can see if it's showing signs of like LVH, is left ventricular hypertrophy, and that's showing thickness of that muscle wall. So your heart's obviously been working harder at times, and it's growing thicker. Just as if you were sitting there and you were doing a bicep curl in your left arm for 30 minutes, that bicep's eventually going to grow thicker and harder. So that's not a good thing. I always say, I want your muscles to grow everywhere in the body, but not the heart. And, so that doesn't look at the outside of the heart though. Yeah. And so go ahead and tell us then how we look at the coronary arteries, which are the blood vessels that feed the muscle of the heart.
So, well, let's talk about another test that people also commonly think of when it comes to screening for heart disease, which is the stress test.
Right.
Stress test, in my opinion, is not a great test for screening a non-symptomatic patient. Stress test may be fine if you are having symptoms. And this test measures your heart function while you're physically active. So they'll usually have you go on a treadmill, and then you'll have a tracer injected in you, and they'll see where it goes into the heart, and it sees where part of the heart muscle may have died, and you aren't picking up that tracer in that area, and it shows signs of ischemia. And it can also show transient, which is reversible ischemia. So I have so many patients tell me, oh, well, my other doctor used to do an EKG on me every year, or my other doctor used to do a stress test on me every year. I just don't believe that these are great tests. There's so many cases of people who've had normal stress tests and then drop dead of a massive heart attack a week later or a month later. Big example would be Tim Russert a few years ago. I don't know if you remember him from Meet the Press, but that happened to him. He had a stress test. It was normal, and then he had a heart attack. So there are so many better tests that we have now for screening and for prevention. So the gold standard cardiac catheterization, that's an invasive test that's typically done in the hospital. And that's a good test for people who are very high risk and for people who you have a high suspicion for who may end up needing a stent. Because while you're in there, it's like doing a colonoscopy where you can remove polyps while you're already in there. Same thing. You're already in there. You can place a stent if you need to. And it's a good indication of the inside of the blood flow through the vessel. But what doesn't it show you? It doesn't actually show you the total picture of the walls of the blood vessel. So there's a test called the carotid intima media thickness test, which is an ultrasound of the neck. And we use the neck as a surrogate representation of all the blood vessels of the body, including the heart. And if that intima, which is the lining, the part of the blood vessel that gets built,
the plaque.
Right, where the plaque builds up, if that's thickened, that's a sign that there could be something going on everywhere, including in the coronary arteries.
The problem in this area, it's hard to find a place that does this. This is a different test than a carotid ultrasound.
Right. It's not a carotid ultrasound, right. But it's a very operator-dependent test. So you really have to know the technician has to be good at doing these.
Right, because ultrasound, it can go off of pressure. And so if you're pushing harder, you have different dimensions than if you're going lightly.
So even though we think it's a great test, it's not a test that we typically do in our practice because we just don't have good access to it.
Right.
And then we have the ankle brachial index, which you already talked about. Mm-hmm. That's the blood pressure difference between your arms and your legs. That is a good representation that there could be blockages in the arteries of the legs, which also could represent blockages everywhere else in the body, including the heart.
It lets us know if there's any signs of ischemia based on a percentage And if there is, then we know we can get it and treat it probably sooner than having an event.
Right.
And waiting.
So then let's start talking about some of the tests that we do commonly do in our practice. The coronary calcium score. Once upon a time, not many people had heard of these, but now they become very commonplace. Typically, insurance doesn't cover coronary calcium scores, and the price range I've heard anywhere from $75 to $300. So it all depends on where you live and who's offering the test. And it's a great test. It looks for calcium deposits in the walls of the coronary arteries. Now, do calcium deposits cause the problem? No, they are not the problem. They're a surrogate marker of the problem. Typically, when you have heart disease, you will have calcium deposits building up. And this is a test that we don't care so much about the number or the score. I mean, we care if it's very high, but you're either 0 or you're not 0, in our opinion. And if you're 0, then it's a fairly low chance that you have calcified coronary artery disease, but it does not mean you do not have coronary artery disease.
Well, a coronary artery calcium score is a 5-year risk assessment. That's what we know. And so it's a good estimate of your next 5 years is the way I like to
provided that
look
you
at
have calcified plaque.
Right.
So here's the limitations of that test. People under the age of 50 will tend to have more non-calcified plaque than calcified plaque.
Right.
So, and that's the bad plaque. That's the dangerous one. The calcium deposits and the calcified plaque are not going to kill you.
They're stuck where they are.
Right.
I think of it as like, yeah, it's calcium, or well, it's not really, but it's calcified, meaning like it's stuck where it is, and it's the soft plaque.
So fossilized plaque.
Right. And it's like the soft plaque around and also causing the narrowing of the blood vessel walls that people don't understand. Kind of like a pipe though. I mean, as you use that analogy, you know, the soft plaque I think of as the loose hair and gunk and smudge that you have. And when that eventually fills up, boom.
Or moves.
Right.
It could slide and block completely. So the soft plaque is the dangerous plaque. It's unstable. It could rupture. And when it ruptures, what your body immediately does is it sends a blood clot there. The blood clot then completely occludes that blood vessel, and that's where you have your heart attack.
Right.
So the treatment is to reduce the soft plaque, not the calcified plaque. And it's, you know, one of those things that when you have a high coronary calcium score and you put someone on a statin and you start shrinking that soft plaque, what's going to happen? The calcium score is going to go up. And they always panic about this. I'm like, look, we're not treating your calcium score. That's not the goal. The goal is to treat what's going to actually be dangerous to you.
Right.
And it's not the calcified plaque. So we use the calcium score, but really we use it with limitations, and we have to understand that it's not the greatest test for everybody. I had a patient in my practice, a 40-year-old who had a coronary CT angiogram, which we'll talk about, which a lot of times when you do the coronary CT angiogram, they will include the calcium score in it. He had major soft plaque in 4 different vessels, ended up needing a quadruple bypass, but his calcium score was 0.
Wow.
And of course, he was of Indian origin.
Yeah.
Right. So these people are at risk and their risk factors are different.
And that's why I like doing the CT angiograms, the coronary CT angiograms. Right. I mean, because that's the look of the soft plaque. And that's why I like to order on women. Women, we know, are at also increased risk of having more soft plaque.
Right.
Women have atypical heart attacks.
But those tests are more expensive, and which is why we don't do them commonplace. Those tests run around maybe $400 to $600, right, somewhere in that range.
But it's the one thing I want everybody to think about, though. This is an investment into your health, and if you get that CTA of the coronary arteries and you get the full look of your soft plaque, your calcified plaque, it can be peace of mind, or it could also be just very informative that it lights a fire under your butt to change things in your life.
And this is another test that you want to go to a place that's good, that has a good machine, and has a good person reading the films, because they will spot things that other people don't do. And it's a CAT scan, so it'll see other things as well. Sometimes we found lung nodules by doing this test. Right. We found incidental things. And it does require that you get contrast. Right. You have to get an IV. You have to have a contrast. And typically, you're going to probably need a beta blocker to slow down your heart so they can get a good image. And you're probably going to need to have nitroglycerin given to you, which can potentially cause a headache. But it's a small price to pay for this test. And the nitroglycerin opens up the blood vessels so you can see a little bit better in there. And that, for the longest time, was our our test of choice. And now we're even better than that. So now we have add-ons to the coronary CT angiogram.
Technology is amazing.
Right. We have the HeartFlow FFR CT analysis, which actually gives you a 3D representation. And
it's color-coded. It's really cool.
Yeah, and it shows the flow within the vessels.
Exactly.
And now we also have the Clearly AI scan, which is an add-on to a coronary CT angiogram, which uses AI technology to look at it even better. And it's super accurate. It's been compared to radiologist interpretation and shown to be far superior. So if you have access to that, and if you're at risk, and if you're concerned about heart disease, you might want to look into getting one of those other scans. The Clearly especially is becoming more popular, and they're doing clinical trials. In fact, we're involved in a clinical trial where we're using some Clearly scans.
So let's talk about treatment. So a lot of, I guess I'll say repeating on this podcast, it's always lifestyle modifications, right? They need to come first.
Always, over everything else. And just because you have a great lifestyle also doesn't mean that you're immune to disease. And just because you find that you have heart disease and then you incorporate lifestyle modifications doesn't mean that you're now free and clear.
Exactly.
But it has to come first. And we know for a fact that diet plays a role, especially reducing your inflammation. And like we said, not necessarily just by reducing fat and cholesterol, but by reducing carbohydrates, reducing sugar, reducing starches.
Right. And if you smoke, stop smoking. Mm-hmm. And if you're a heavy drinker, cut back. Just little changes like that.
And what about your favorite topic, exercise?
Exercise. 15 minutes a day. That's all it takes, And I mean, there's some statistics out there that say you can reduce your heart disease by a certain percent if you walk 4,000 steps per day, and this percent if you walk 10,000. I mean, just move. That's all it takes. Just move.
It does. But weight training also helps. Building muscle.
Course.
Muscle is important.
Muscle burns fat. Mm-hmm. So it also reduces your visceral fat, which is what we know can cause diabetes and heart disease. So there are interventions if somebody actually does have a large amount of soft plaque shown on a CT angiogram, or even a high amount of calcified plaque.
And we used to commonly do stents in patients, but there's a study, the ischemia trial, which actually looked at stenting versus maximal medical therapy, and they found that in asymptomatic patients, there really wasn't any difference between putting a stent in someone and treating them maximally with medication.
They basically showed that it didn't prevent, right?
Right. So bypass surgery also is an option. But so number one in most cases in this country are going to be statins. And statins are very controversial, and they become more controversial in the last few years with TikTok and other
podcasters.
So statins are both overutilized and underutilized, in my opinion. I think everyone with high cholesterol needs to be on a statin? Absolutely not. No. And there is so many people who are on statins just because of something abnormal in their blood test. Or
because they went to their traditional doctor and got a calculated LDL that was high, but then they didn't check any of the other factors.
Right.
And, that's where we take into the whole picture, your family history, your genetics, and all of these labs. And there, we can monitor, but our thing is, let's send you for some imaging, like we mentioned already above, and we can use that as a collaborative risk factor as well.
And let's see what let's see what your true risk really is.
Right.
But in our practice, we have gotten probably as many people off of statins as we've put on statins.
Right.
And statins, they've gotten a bad reputation as well. People feel that statins can cause memory loss and can cause some cognitive impairment. And we've looked at the studies. I mean, there are some detailed studies that they've done, and they haven't found that yet. That's not to say that they may not find it. Statins can potentially cause muscle aches. It's just the way they work. We know that statins can deplete CoQ10, so we like to put most of our patients who are on statins on CoQ10 as well. There's other things that people have said that statins can do or can cause. And I have not seen much evidence that it happens, but I am not saying that they're completely benign drugs. And I'm not saying that they should be used just indiscriminately. It's not like something they should just add to the water.
Well, I think a lot of people have this controversy about how low the LDL should go, right? And in the functional realm, they like to say we need cholesterol for our hormones, for our brain. And yeah, that's true, but this is different cholesterol. This is not the cholesterol that's plaque causing and atherosclerotic.
Right.
So we can have good cholesterol with your omega-3s and with olive oils and eating a Mediterranean diet and nuts, and go back and listen to our nutrition podcast right now if you are curious what the diet is that you should be eating. So, there's ways you can get good cholesterol. So you have to, we kind of take that into consideration, and we'll work with you if you have concerns on these issues. And of course, we're all about trying not to put you on medications if you don't need it. But if we see you are at risk of having an atherosclerotic event, we are going to try to reduce that risk. And we'll have that discussion with you.
And the guidelines are still, like I said, in this country, if you have heart disease, you need your LDL less than 70. And if you were in Europe, you'd need your LDL less than 50. And we tend to believe the European guidelines. So let's talk about cholesterol. Cholesterol, 80% of your cholesterol is being manufactured by your liver. It has nothing to do with what you've eaten and what you've done. So your liver is not only making cholesterol, but it's also removing cholesterol.
Right.
So you have receptors. And a lot of times the problem is a receptor problem in the liver, where the receptor is not working optimally like it should. So when we have someone who's on a statin and they're not at goal, we've found that doubling or increasing the statin doesn't do as much as adding on something else. So one of the drugs that we will add on to a statin is something called ezetimibe, which is also Zetia.
But I find that this, we know this only is for the 20% of cholesterol that you ingest. So the dietary cholesterol. So, if you're eating plant-based, vegetarian, true vegetarian, not high-starch carbohydrates and sugar vegetarian, but if you're eating very clean and healthy, this addition is not most likely going to help you very much.
No, but it seems to boost the effect of the statin a little bit regardless. And then another medicine that we're big fans of is bempedoic acid.
Right.
Which
the studies on this is amazing.
Goes by the name of Nexletol. But we don't like bempedoic acid by itself. We like it when you combine it with the ezetimibe, and that's a drug called Nexlizet. Mm-hmm. And again, these are add-ons that you add on to a statin, and they work great. And we get significant LDL reduction when we use those. Then another class of drugs that's out there are the PCSK9 inhibitors, and that's Praluent or Repatha.
Right.
And they are injections, although we are doing clinical trials with an oral PCSK9, which seems to be very promising as well. And these medicines work on the LDL receptors. So PCSK9 is almost like a super glue that sits on the receptor, and the LDL attaches to it and can't come loose. So the body then digests the receptor and the LDL itself, so you don't have as many receptors. So these medicines help at that level.
They're phenomenal, and their side effect profile is minimal.
Yeah, we almost never see side effects.
Right.
Maybe an injection site reaction, but they're typically injections that you give yourself at home every 2 weeks.
2 weeks, yeah.
Then another newer medicine is inclisiran, which goes by the name of Leqvio. And that's also an injection, but you go to an infusion center to get it every 6 months.
Right. You get one shot at baseline, then you go again at 3 months, and then from then on, it's every 6 months. And I've seen phenomenal results with this as well, and also a very low side effect profile.
And you have to remember, these medicines are also best used as add-ons to a statin. None of these are standalone medications.
And the one thing I like to, once again, we do try to get people off of medications, but sometimes we won't be able to get you off of your statin, but we can at least reduce the statin dose if we can, based off your numbers and your lifestyle changes. So we work with you to do this. And I've had some people where I was able to do that, where they were on rosuvastatin like 40 milligram, but with the addition of this medication, we were actually able to come down to 10 milligram, and they said that they already just feel better, less achy, less joint pains.
And then there's some supplements that we use in adjunct to treatment as well. We like one called Arterioscel, which works on the endothelial lining of the arteries, and it's almost like helps form like a Teflon coating,
right,
so to speak.
And that's where I feel like anybody who has the LP(a) elevation would probably benefit from the Atherosclerosis.
Right. And
to help repair that.
We use it a lot. There's berberine, which helps with insulin resistance, helps with glucose. Of course, we talked about CoQ10.
And niacin alone.
And niacin and omega-3. Big fans of omega-3
right.
Fish oils. And just getting more omega-3 fish in your diet.
Right. And as we've already mentioned before, just having high triglycerides alone can also put you at risk for having atherosclerosis. So there's also a prescription medication out there called Vascepa, which has had phenomenal cardioprotective data.
And then there's other drugs that just by coincidence happen to have a side effect of lowering cardiovascular risk. Some of the diabetes drugs.
Correct.
Ozempic. Everyone talks about Ozempic for weight loss, but nobody ever talks about Ozempic for heart disease.
Right.
And it has been shown to reduce heart risk. Same with some of the medications that we use to reduce sugar that's going through the kidneys.
The SGLT2 inhibitors, exactly. Like Farxiga and Jardiance, they also have cardiovascular data out there as well, which is phenomenal.
And there's so many blood pressure medications also have been shown to reduce risk. If you have high blood pressure, you got to get the blood pressure under control.
Exactly.
So as much as we like to reduce the medication burden in our patients, there's some times where you need them. And because the last thing we want to do is see one of our patients have a heart attack or a stroke that could have been avoided.
But prevention is key. So if you are young and healthy now, keep that way. And if you can do anything to prevent these issues in the future and going on medications in the future, do your best.
And as there's so many things that are coming on the horizon, amazing things. So as many of you know, we do clinical trials in our practice. And one of the clinical trial drugs that we are going to be starting to investigate very soon is a CRISPR-based gene editing technology. It's one shot. It's for people with familial hypercholesterolemia. I mean, these are people with a genetic defect, but it fixes that gene and their cholesterol goes from sky high down to very low.
This is stuff that Tony Robbins was talking in his book, Life Force. So I'm super excited. I've been waiting for technology like this to come out.
Right. And so, we'll have to see the long-term effects, make sure that they're safe and make sure that there's no downside to them.
And to actually have risk reduction. That's
exactly.
the proof.
But if the main takeaway point is know if you're at risk or not at risk. Start there. And then we can worry about treatments. We can worry about all the things after that. But if you're just having a basic cholesterol test and thinking that that's all you need, it's not enough.
Thank you for listening, everybody.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.